Hello, everyone. I'm Dr. Neema Bhatt. I'm a senior consultant hematologist. That means I'm a blood cancer specialist and also a bone marrow transplant physician. I deal with blood related disorders and blood cancers uh, in patients of all age groups, adult and pediatric, patients in the elderly age group as well. As most doctors would tell you, and if you follow statistics closely in cancers and medical conditions in people in the senior age group, about 60% of new cancer diagnosis or new cancers are detected in patients who are 65 years and older. By 2030, 70% of all cancers will be diagnosed in seniors. We have, of course, a growing elderly or senior population because with the advent of new medications, new medical technologies, new stents, valves, etc., and advanced medical procedures, we are able to extend a person's average expected lifespan significantly, not just globally, but in India as well. And because of that, India's elderly population is projected to reach approximately 194 million by 2031. As age or life expectancy of an average individual increases, we know that our body goes through changes that come with age and exposures to different lifestyle factors. And cancer is one of those diseases that is more common in the elderly population. So, cancer is the second leading cause of death in older adults. Most often, the first leading cause is heart disease. What we need to understand, especially because we're talking about cancers in the senior population is you're looking at anybody who is 60, 65, and older. So, cancer care for seniors, we know, is not just about treating the disease, it's about preserving dignity, making sure that these patients, despite having a diagnosis like cancer, still have as close a lifestyle to normalcy as much as possible. They don't lose their independence and they preserve a good quality of life. So, those are the main goals of treatment of any disease in people in the senior age group population. Next slide. So, what are some of the challenges that we face that are unique to the senior age population, especially when it comes to cancer patients in the senior age? And why is it that one size does not fit all? Why is it that caring for a person with cancer in their 30s or 40s is very different, or caring for an elderly person with cancer is so different from caring for a younger person with the same cancer sometimes? So, for one, as I discussed earlier, as patients age or as people age, we develop different organ problems. So it can be something like diabetes, hypertension, various heart problems. It can be kidney issues, liver issues. Most of these start cropping up after the age of about 50, 55. And by the time an individual is around 65, 70 years of age, most often they have all of these in their medical diagnosis, which is diabetes or sugar, BP or hypertension, heart problems, a lot of times thyroid issues, liver or kidney issues. Even though they may not be diagnosed with a specific disease specific to the organ, we know that as we age, organs also age. So, definitely, even though the kidney functions may appear normal on paper, the function of a 65-year-old's kidney is definitely going to be suboptimal or not exactly at par with the function of a 40-year-old person's kidney. So, what I'm saying is, even though the organ functions look normal on paper, the organ functions in principle may be slightly reduced or may not be as robust to take even a slight hit, especially when it comes to medications. And I'll come to that, as we talk about it further. The other thing is polypharmacy. So yes, of course, we have medications to treat all of these conditions, but that comes with sort of a cost because each medical condition adds a new drug, sometimes two new medications to the list of medicines that an individual is taking. So With more medications comes the risk of drug-drug interactions, comes the risk of adverse reactions between drugs. So it's extremely important to keep our eyes and ears open and make sure that anytime a new medicine is added, we ensure that it's not interacting with any of that patient's individual, existing medication. So it's very important to sort of go through the existing medication list and then add a new one after ensuring that it's not going to interfere with the balance. As we grow older, we go through a lot of cognitive changes. So, patients who are in their 30s or 40s may have a different kind of motivation or drive to continue treatment or stick to medications or make sure that they are, very compliant with their medications. But as people grow older, their drive or motivation to continue or see a treatment to completion, and hence their motivation to stay compliant or adherent to treatment, changes. So as we grow older, we all know, and we have seen patients go through this, that they feel that their life is already complete. They don't really see the need to add a new medicine to their already existing long medication list, and they're not able to decide, is really taking treatment for this condition going to alter my quality of life? Is it really going to make it better? And is all this pain worth taking? And we see elderly people sort of struggling with this kind of decision making on a regular basis. The other aspect that is not as addressed or as strongly looked at, but is equally important, and in fact, if you look at the overall picture, is very, very important, is social isolation. So, with the younger population, the younger generation migrating outside of India because of better job prospects, because of better educational prospects, we know that there is sort of a residual senior population that is left behind with a very poor support system. Most of their children are outside, their siblings who may be younger than them and capable of taking care of them may be outside India. So they may not really have a very strong support system, save for maybe a caretaker or a maid, or someone else who's not as reliable when it comes to important decision making. Also, there is a risk of social isolation. So, I've had patients who have lived in the US for 15, 20 years. They have then moved back to India because they want to be closer to their roots, but they don't really have a social support system over here. They are unable to make friends because they've sort of left their social life behind over there, and they've moved back here, and they face depression. So they're not able to find people of similar wavelengths to hang on to, hang out with. They are unable to carry out social activities like the rest of the people over here. And that applies whether you've lived in India, lived outside of India, moved back, if you've relocated, if you don't have a great social support system. They tend to go into, states of depression just because they don't have a social support system to keep them or take them through this journey. One more aspect that is as important as the medical part and the social part is nutritional. So we know that food intake in general and the patterns of food intake changes as people age. You're not as conscious about the amount of protein you're taking. Your physical activity is different from what it was when you were in your 30s, 40s, or 50s. You may not really pay as much attention to the amount of vitamins you're taking because you think, okay, most of my physical activities are dealt with. I'm probably going to be a little bit more sedentary than I was earlier, and I don't really need to pay attention to what I'm eating. So it's very often that we see iron deficiency, we see vitamin B12 deficiency, we see vitamin D deficiency, we see micro element or vital elements deficiency. So nutritional deficiencies are fairly common in the elderly population. Mainly because of dietary insufficiency and also lack of awareness. They don't go through testing on a regular basis. They don't test for nutrition deficiencies on a regular basis, hence causing them to have deficiencies and still go undiagnosed. And as we all know, cancer and making sure that cancer is addressed the right way in a comprehensive fashion requires patients to have the right medications, requires patients to be able to make the right decisions, requires patients to have the right social support system, as well as requires them to be nutritionally robust so that they are able to fight a disease as big as cancer with all the vigor that is possible. Next slide. So, what is the best way to assess whether a patient is actually doing well, how well they are doing from all these aspects? There is something called Comprehensive Geriatric Assessment, or CGA, and it is founded by the Foundation of Senior Cancer Care. The aspects by which we evaluate an individual is their functional status, which is how capable of performing their daily activities they are, their cognitive function by testing memory, decision making capacity, by testing their nutritional status, by making sure that they're not losing weight, that their appetite is still preserved, that the patients don't have any risk of malnutrition, just going by their social, social network status, and also making sure to go through their nutritional practices. Psychological health, by assessing them for depression and anxiety, ensuring that there is a strong enough family support by involving the family whenever the patient comes for a follow-up, involving the family when it comes to decision making, and ensuring that they have a proper caregiver by asking them what kind of a caregiver facility is available. Other comorbidities, by making sure to get a full medical history. And it's very important that when an elderly patient even comes for a regular follow-up visit with an existing diagnosis of cancer, always ensure to run through their list of comorbidities and ask, have you seen your geriatrician or have you seen your physician recently? Has there been any new diagnosis, any new medications that has been added to your list? Because anytime we have to add a new medicine to their list, we need to be aware of their comprehensive list of medications. And there is evidence to support that CGA identifies problems that are missed in about 50% of standard oncology evaluations, and it is able to predict treatment toxicity with 85% accuracy. So, if you follow the guidelines and make sure that you follow the CGA assessment, it's just comprehensive enough so that you don't miss any of these details. So, it's important for oncologists to remember this and make sure to follow it up in every follow up appointment. Next. What is the other best thing you can do? It is tailor treatment approaches. Of course, protocols help when we have to make sure that things are being followed properly and nothing is missed out. But where the extra step matters a lot is where personalization is added on top of protocol. So we know that, yes, protocol does take care of most of the issues, but when it comes to each individual patient, on top of protocol, also assessing that where is their biological status. So there is something called chronological age and biological age. Chronological age is your age, that's your number on the paper. But biological age refers to how fit a person is when it comes to their appearance, when it comes to them carrying out their daily activities, when it comes to their nutritional status, when it comes to their fitness levels. So all that gives us an idea about a person's biological age. And that's what I mean when I say personalization on top of protocol. Of course, following protocol to start with, and then seeing how a patient tolerates the treatment that is planned for them, making sure that each patient, despite having the same diagnosis as another person who's the same age, taking into consideration all these other aspects, if the treatment plan is personalized, then they tend to do better. So, for example, when we start, because I do hemato-oncology, so we design oncological protocols for our patients with lymphoma, myeloma, leukemia. So we start with lower adjustments, so chemotherapy doses adjustments. If a patient is, say, 40 years old or 50 years old versus 70-year-old, there is definitely going to be a higher side effect potential for the 60 or 70-year-old compared to a patient who is only 40, 45 years old because of all the factors we've discussed so far. So starting with a slightly lower dose, seeing how they tolerate it, how their body is able to adapt to it, seeing if they have any kidney malformation or any renal problems, if they have any liver issues because of which doses need to be adjusted, because of which certain medications cannot be delivered safely based on their organ function. Monitoring these patients on a closer interval. So you would bring back a 40-year-old patient, say after 3 weeks for a follow-up. But when it comes to an older patient, so if it's a 70-year-old, I'd probably ask them to come back within a week, just to make sure that if at all, they're having any side effects from the medication delivered, we know sooner than later that they have to be monitored. Making sure to be more proactive with the supportive care, ensuring that you talk to the patient. Okay, you have someone to bring you to the hospital in case you have a side effect. How far are you from the hospital? Do you need to have the ambulance number? You need to inform your neighbors. So somebody has to be aware that you're going through this treatment and you might have a side effect that requires you to be brought to the hospital at the earliest. All these is a matter of sensitizing the patient, because they may be all consumed with their diagnosis and they may not really think about, oh, hey, if something goes wrong, if I have a side effect, how do I really address it? How do I get to the hospital in time? So they may not have all these practices or the support system in place. So just you doing a quick rundown through these questions or these aspects helps the patient think about it and say, okay, this is what my plan is, and helps them be a little more ready. Considerations when it comes to surgery, as minimal as possible, as in not very invasive procedures, because they're less likely to tolerate invasive procedures. Making sure that they are nutritionally well preserved. So that's called prehabilitation. So even before the surgery happens, ensuring that the patient's nutrition is good and they have a post-op plan all set in place, and making sure that the recovery is faster by mobilizing them at the earliest, providing physiotherapy support at the earliest, again, staying on top of any infection that might happen, any nutritional issues that have to be taken care of. So other than over and beyond what you would do when you're considering surgery for a younger patient. When we come to radiation therapy, because when it is any cancer, we talk about chemotherapy, surgery, radiation, of course, immunotherapy, targeted therapy, and all of those. So surgery and chemotherapy, immunotherapy is what we've addressed. When it comes to radiation, older patients we know cannot tolerate higher fractions, higher dose per session. So it was very important for the radiation oncologist to make sure that they're delivering hypofractionated schedules, which is sometimes it can be fewer number of sessions. It can be the amount of dosage of radiation that's delivered per session. It's very important for them to take a call based on the biological age and the support system of the patient. Also, one of the things we try to ensure after a particular plan has been set in place and we get an idea how the patient is tolerating is to see if we can reduce the patient's number of visits to the hospital. So that is what we mean by by planning to give a good quality of life, is you can lead almost an independent quality of life, as much away from the hospital as possible, feeling that you're independent and not really feeling like a patient. That is the goal of treatment when it comes to any treatment in the elderly. It should also apply to oncological practices as much as possible. Next slide. So what do key research studies tell us? So evidence supporting the senior specific care. So if you look at SIOG guidelines, that is International Society of Geriatric Oncology, it recommends that CGA before all treatment decisions in patients that are 65 or 70 plus. NEJM palliative care study that early palliative care integration increased survival by 2.7 months, as in making sure that all the nutritional, the infection protocol, the supportive care protocol, everything is set in place, ensures that survival of a patient significantly increased. Their quality of life was significantly better, and it's particularly impactful for seniors if you put all these practices in place. Older patients with proper geriatric assessment had 40% fewer hospitalizations. I think 40% is a significant number. So this study was conducted with the Lancet Oncology study and showed that not only did it reduce hospitalizations, it also improved the treatment completion rates by about 35%. Imagine if 35% higher of your population is actually going to treatment completion just by paying attention to a few smaller details. I think that is a It's a very non-medical way of improving outcomes, not just by finding a new drug or finding a new surgical technique or finding a new instrument. This is very small things that count in helping the outcomes of a patient. The Indian Cancer Society data showed that only 20% of Indian seniors currently receive geriatric oncology assessment. So yes, although there are a lot of oncologists, we don't have very many settings where we have an oncologist and a geriatrician coordinating the care of a patient. So when we look at the geriatric population, just like we would look at a pediatric population, it's very important for us to identify that this sect of people or this sect of patients is very different, not just medically, but socially, nutritionally, mentally, emotionally, physically. They're different in all aspects compared to your standard population database of 20 to 50 or 60. So ensuring that you're working with a geriatrician or at least following the geriatric guidelines to make sure that you are structuring your patient's treatment well is very, very important for long-term outcomes as well as patients' compliance to treatment. Next slide. Another aspect that we should look at more seriously, especially in the elder population, not because outcomes are bad in all older patients with cancer, but it helps and gives a real time idea to most elderly patients if we include this discussion at the beginning or as early as possible without a negative impact on the patient is palliative care. So the idea that comes up to our head when we talk about or think about palliative care is end of life. Okay, if you're talking about how to support the patient better, that means he's not going to survive the cancer or the cancer is just deadly. But that is not the idea we want to put into people's head. So palliative care is meant to be more of supportive care. So we call it best supportive care. So if palliative care sounds too harsh or end of life care is too harsh, we would like to think about it in the way of supportive care. So this aspect should be addressed right at the beginning of the diagnosis and not only if we're looking at failure of treatment or end of life care. So what exactly is best supportive care? Making sure that pain of a patient and any pain symptoms and other discomfort symptoms are addressed and managed adequately. Emotional and psychological support, making sure that we are also addressing the emotional and psychological aspect, if required, taking the help of a psychological counselor. So we have someone who's called a psycho-oncologist or oncopsychologist. So basically, they are psychologists with a background of working with patients with oncological diagnosis or with cancer diagnosis. So it's very helpful to involve them because as an oncologist or as a hemato-oncologist, I may not have enough time or means or the complete bandwidth to address the medical part, the nutritional part, the social support part, and also the emotional part or the psychological support. So I think as many sort of smaller or different specialties or specialized people we can take the help of to take care of the special population, the better it is. Also, sometimes psycho-oncologists can help with treatment decisions, having an extra meeting with a couple extra family members who may be part of their support system rather than meeting with just the patient can help the patient make a significant decision change. Make sure that you're involving the caregivers when it comes to decision making and not speaking just to the patient, making sure that there is coordination between specialists. And I think that's where a geriatrician would be very important, or they play a very important role in ensuring that, okay, I'm taking care of the cancer, but who's looking after his kidneys? Who's looking after his liver or his sugar or his BP? So that to sort of delegate it to the specific specialists so that nothing is missed out, or having a geriatrician sort of oversee or overlook the entire care of this patient would be apt. For seniors, palliative care sort of addresses and puts into perspective or clarifies their doubts about them losing independence, their concern about being a burden on the rest of the family or on the society. Palliative care should be able to address multiple symptoms simultaneously. And at the end, we all want to lead a dignified life. We want our elderly population, we want our parents, we want our in-laws, we want our friends to lead a dignified life despite having a diagnosis that can be as harsh as cancer. So Palliative care mainly prevents and relieves suffering through early identification and treatment of pain, other problems, whether it is physical, psychological, psychosocial, or spiritual. This is the saying of World Health Organization, and I think only by practicing all of these aspects can we aim to deliver world-class oncological care as well. Next. Caregiver support, so the hidden heroes, the family involvement is critical. So 70% of cancer caregivers for seniors are family members. How can we support the caregivers? Mainly try to educate them on medication management, training for side effect recognition, emotional support and counseling, make sure that they have respite care resources, clear communication channels with medical team is important. 24 hours a week approximately should be spent on caregiving. 40 to 70% of patients or of caregivers experience distress. They experience significant caregiver burden. So making sure that the caregivers understand the treatment plan, know the warning signs that they need to know to watch out in the patient so that they know when to bring the patient or when to contact the doctor for the immediate attention. Having emergency contact numbers ready, having the ambulance number ready, having the emergency number ready. If possible, having your doctor's number ready, although the doctor may not be in a position to do much except for you to tell, okay, take the patient to the emergency. So having all your important numbers ready, having a good cab driver if you're not driving. So all these, having them ready reduces the caregiver burden or anxiety that comes with taking care of an elderly patient with cancer. Making sure that you're taking care of your own health. So being a caregiver does not exempt you from diseases. You are still at risk for developing diseases or having a new diagnosis just as much, even if you're taking care of another person. So very important, since you are the primary caregiver for that particular patient, that you are ensuring your own health checkups are done in time and you're not lagging behind on your own health, sleep, nutrition, and physical fitness. And I think one last aspect that is up on the slide that is very key and really, really important and cannot be enforced to its max potential is trying to accept help from extended family. So, being an oncologist who's practiced in the US and in India, the harsh reality, sort of comes forth when you ask a patient, is there this history in your family? Do you know if somebody else is taking similar medications? Do you know if somebody was diagnosed with a similar condition? Most often the answer is, I don't know. We never talk about this. I don't know. I think they may be on it, but they've never discussed anything about this. I have never asked my family members if they have any medical conditions. We talk about food, festivals, marriages, birth, like everything under the sun. We gossip, we share, lots of happy moments. Why do we not discuss about our health, especially a diagnosis like cancer? It's almost taboo for a family member to discuss, I have been diagnosed with this type of cancer. I am going through this treatment. This is the difficulty I am facing. These are the challenges I am facing. These are almost never discussed, no matter how progressive the family is, no matter how well educated they are, no matter where they live. There seems to be a huge disconnect between patients and family members discussing about each other's, especially cancer diagnosis. Now, this differs from the West, and I'm not saying somebody is right or somebody is wrong, but it's just a matter of practice and it's just a matter of confidence when you know, okay, somebody else in my family or in my extended family or my friend circle has gone through this and has come out through this successfully. These are the means they used, these are the support systems they use, these are the things that can help me, that has helped them get through this. Just by being open about your diagnosis, just by being vocal about it, and by sharing your experiences, sometimes not just to your family and friends, but to the rest of the community. Like you're going for a prayer gathering, so you discuss that this is what I'm going through, this is what I have to deal with. Yes, it may cause you pain when you know that, okay, other people are talking about your diagnosis, but you should look beyond that and say, okay, this is how I can seek help from my extended community that is close to me and that cares for me, this is how I can help them in return if they are ever faced with a similar situation. And I think we need to look beyond the taboo that comes with cancer diagnosis and look at it as, okay, this is a community issue. This is a family issue. We need to address this as a family rather than keeping it in silos and just keeping it to ourselves and not discussing about it just because, oh, hey, I've been diagnosed with cancer. I don't want anybody to know about it. So I think our mentality as a family, a community, as states, as a whole country needs to see a huge sea of change so that we can look at discussing cancer diagnosis as helping other people rather than, they're going to look at me differently. They're going to judge me. They're going to think I did something wrong. So I think we are looking at it a little bit in a very conservative fashion when it comes to a diagnosis as such. Next slide. Okay, I think we already addressed this, but very important to ensure that nutrition and quality of life have to be addressed when we are taking care of a patient with cancer, because that forms as important a part of their treatment as do medications and surgery or chemotherapy or radiation therapy. So I think quality of life and nutritional quality or nutritional status are extremely important aspects that have to be addressed.